Dear friends, ladies and gentlemen, it's really a great pleasure and honor indeed for me to be here on the occasion of a very important mission. And the mission is how to reduce sympathetic overdrive in Indians and in the globe. It's a real challenge for us. Every possible cardiovascular disease has its roots only in three components. Either there is an increased SNS or increased RAS or increased NPS. But all three are regulated by sympathetic overdrive in one way or the other. So our main objective is to discuss on the role of beta blockers. Role of beta blockers cannot be overemphasized. It's known to each and every one of us. The oldest molecule which we use here is metoprolol, 44 years old molecule, while bisoprolol, 31-year-old molecule, and 28-year-old molecule is carvedilol, while 26-year-old molecule is nebivolol. But if you see the Trivandrum heart study, which is shown very clearly, and I remember it's a 5-year follow-up data, which is shown that the mortality is up to a tune of 59% in heart failure patients, out of which sudden cardiac death is 46%, which is a huge. And 25% of patients who were given GDMT, their survival was better. So that's how we started working on the role of beta blockers in heart failure. I remember the word of Kushank, who mentioned once upon a time that the beta blocker was a contraindication in heart failure, and then it became an indication of heart failure, and then it became a compulsive indication for heart failure with reduced ejection fraction and mid-range ejection fraction. So it is a drug of choice. So beta blockers have a role in heart failure, in resistant hypertension and hypertension, metabolic syndrome, in the patient with obesity, atrial fibrillation, in patient with tachyarrhythmias, migraine, anxiety state, and Marfan syndrome, and even stress cardiomyopathy. So what not? There is huge potential of beta blockers. I would just like to give a comment on the promise of drug like bisoprolol in the heart failure or hypertension, and of course other beta blockers like metoprolol and to some extent carvedilol. We don't use atenolol anymore because it increases central aortic blood pressure. Various trials like CBIS 1, CBIS 2, CBIS 3, Copernicus, Comet trial, senior trials, and Trivandrum heart failure study has given a new vistas. And recently, European Society of Cardiology has published a paper which was just shown 2 months ago in the conference in Barcelona. What are the messages? The messages are the drug like bisoprolol is a beta blocker of choice in heart failure with reduced ejection fraction on mid-range ejection fraction, having an enormous mortality benefit. Our aim is to achieve the target heart rate, maybe with or without target dose, depending on the sensitivity of SNS. And the beta blocker maximum dose of bisoprolol is 10 milligrams, 200 milligrams of metoprolol, and about 25 milligram BD of carvedilol. These are commonly used. So bisoprolol has been shown to be super selective beta blocker, which is 3 or 4 times more than the metoprolol and carvedilol or nebivolol. It has been documented very clearly that the sudden cardiac death can be reduced up to a tune of 45% in heart failure, which is an enormous benefit. The robust survival benefit is by beta blocker. And reduction of morbidity, reduction of mortality, hospitalization with the heart failure, event rate reduction, every possible thing, MACE rate is reduced with beta blocker. So I must tell you today with a great confidence that the drug like Bisoprolol has come to stay along with metoprolol and carvedilol. Its power and promise should be very well known to you, especially in heart failure, in resistant hypertension, in patients with CKD, in atrial fibrillation, tachyarrhythmias, because this is a very, very potent beta blockade effect. The carvedilol and nebivolol have a little vasodilator effect, but sympathetic drive can be reduced very effectively both with bisoprolol and metoprolol succinate and metoprolol tartrate. So my message to conclude, ladies and gentlemen, is very clear that sympathetic overdrive cannot be misunderstood, ill understood, or not understood. And number two, controlling the sympathetic overdrive is the need of the hour. And number three, it's possible by using an effective dose of beta blockers with target heart rate. The target heart rate should be 55 to 64 as per the consensus which is accepted globally. And the Trivandrum heart failure studies have given us a lot of insight to the usefulness of beta blockers, especially bisoprolol, for reduction of sudden cardiac death up to a tune of 45 to 46%, which is a huge benefit. All-cause mortality reduction, hospitalization reduction, as well as reduction of MACE. So I think use beta blocker in effective dose. Reduce target heart rate to an effective level. Then only we can reduce the morbidity and mortality in heart failure, hypertension, and other comorbid conditions like atrial fibrillation or tachyarrhythmias in a patient who are suffering from metabolic syndrome. Thank you very much for giving me this honor.